The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Yes, thank you, and I apologise for the title, which is a little wordy in retrospect. So I've been really impressed over the last couple of days by actually how consistent some of the themes have been and how the same problems really are universal across Australia and New Zealand, and I think wider than that. But I'm quite excited to tell you about this because we've implemented a system at Royal Perth Hospital that we think has addressed quite a lot of these problems. And although the specifics are for our hospital, I hope some of the principles you might be able to take away and apply elsewhere. So just to give you some context, Royal Perth is a 450-bedded tertiary unit. We predominantly regard ourselves as an emergency hospital. We've got about a 70-30 emergency elective split with a state trauma unit, and we've got most medical and surgical specialties on site. In 2014, there was a bit of reconfiguration of health in WA, and I became a consultant at the tail end of that. And one of the projects I was handed at the beginning, starting as a consultant, was to try and sort out of hours, which was a bit of a poison chalice in retrospect. So we know out of hours is a problem. It's a problem internationally. Over here we've got some data from the UK. This is registry data showing that if you have your cardiac arrest at night, your odds ratio of survival to hospital discharge is less than 0.6 compared to if you have that same cardiac arrest during the day. And our data in Royal Perth, if you were admitted at the weekend, you were significantly more likely to die than if you were admitted during the day. Now, you can explain that, and you can say it's because the patients are sicker at the weekend. You can say that there's lead time bias for tertiary hospitals, so you're going to get sicker people at the weekend. But we thought that there was an opportunity to improve, especially because we were seeing some other signal. Our junior medical staff were grumbling. That happens, but they were particularly grumbling about the workload, heavy or very heavy, 77% felt. 60% almost felt that they could only occasionally review a patient in a time that they regarded as appropriate. 60% said they rarely got breaks, and 56% said they wouldn't be happy for a relative to receive the care they were providing. And at the same time we were seeing adverse events, we were seeing consistent themes in those relating to leadership, communication, governance and accountability out of hours. Now, I don't think those are unique to Royal Perth, I think those are shared, but we were worried about them. And when I came in, there'd been some previous work, actually quite a lot of previous work done on this. This wasn't a new problem. And there'd been various root cause analyses showing these same features: inexperienced staff shortages, failure to monitor. And lots of processes have been put in place to try and mitigate those, things like structured handover, isobar format, documents relating people's roles and responsibilities. They were all great, but fundamentally they were trying to patch a broken system. So in 2015, we felt, have we got an opportunity, while the health service is being reconfigured, to actually rewrite how we deliver out-of-hours care? And so what we did was we used a Safety 2.0 framework rather than this relatively old-fashioned way of doing it. And we looked at how successful clinical teams operate and tried to build our system based on that. So what we looked at was how successful teams during the day work. And there's a few things we noticed. Firstly, successful clinical teams tend to be part of successful clinical departments. They've got leadership, they've got accountability. Successful clinical teams know who their sick patients are, and they proactively assess them and solve their problems before they deteriorate. They go back and review them. They take ownership of the problems. They don't wait till the end of the shift hoping someone's going to come along and rescue them. If there's a problem, they fix it themselves or they find someone to help them fix it. And they've got an attitude that their responsibility is to actively progress patient care. The other thing that good clinical teams do is they appropriately delegate decisions. So the consultants are making the consultant level decisions, and the juniors are empowered to make the decisions they can. Now, not all of those features actually relate to the out-of-hours workplace, but what we tried to do was take those features that could apply to out-of-hours and apply them as we could. So the first thing we did was actually form a department of out-of-hours. We called it SAFE, Safety After Hours for Everyone. And one of the first things that we did was to appoint me as head of department, which was great for me. But it was also great for the hospital because it meant that for the first time there was one person who was responsible for out-of-hours care. So if a specialist is unhappy with what's happening at night, they can come to me and I can fix it. But if the night team are unhappy with what's happening during the day, they can also come to me and I can try and fix it. It means the quality improvement that touches on nights, people can come to me. Is it deliverable? Can I help people deliver it out of hours? But the other really important thing about being a department is that it meant that we could be accredited for training, which meant that we could actually have, instead of having scattered RMOs for a single shift, registrars borrowed from other departments, we could actually have registrars and residents for full terms, which meant that we could provide an education package. It's not rocket science, it's just what do sick people look like, what should you do about them. But even more important than the education, we could actually generate a culture where at night we have an opportunity to make our patients better rather than just crossing our fingers and hoping they're not getting worse. The other thing by being a department is we were able to appoint some permanent senior nursing staff to act as a leadership cadre within the hospital out of hours. Probably the most important thing is that actually it demonstrated to everyone in the hospital that out of hours was a priority, that executive placed a premium on out of hours care and that it was important. So on the left here is just a diagrammatic representation of how we operate out of hours. So the team runs from 4 in the afternoon till 8 in the morning, 5 days a week, well, Monday to Friday, 24 hours, Saturday, Sunday, public holidays. We've got a team of 5 residents who are ward-based. They're allocated on average about 60 patients across their wards. They're coordinated by a clinical lead who's a senior nurse, who maintains oversight of who the sick patients in the hospital are. The clinical lead knows both who's sick, who's responsible for seeing them, what the plan is, and is in a position to follow up whether that plan is actually happening and whether the plan's working. They're authorized to escalate any problems inside or outside the hospital, so they can address ICU if there's an issue, or they can ring the patient's consultant or any other consultant in the hospital if they feel that's appropriate. On site, they're directly supported by a dedicated registrar who provides immediate clinical support for these RMOs, alongside the senior nurses who are already present in the hospital and the physiotherapists. Obviously also in the hospital are the other teams that are relevant, so ICU is there, anesthesia, ED, and the surgical registrars are on call or on site. So one of the key features is our handover process. So the start of every shift obviously has a handover. We structure our handover around a list of patients of concern within the hospital. They're the patients that we regard as most likely to deteriorate over the next time period, whether that's because the nurses or doctors have a specific concern about them or whether they meet these pre-agreed criteria. They've already deteriorated with a MET call in the previous 24 hours, recent ICU discharge, physiological derangement. At the end of handover, the whole team has a shared knowledge of all of those patients, so the residents know in their area who they expect to see, who they can expect to be reviewing, and the clinical lead and registrar know who's sick in the hospital. At the end of handover, the resident's first role is to go and review those patients of concern, find out what's going on with them, so they can feed back to the clinical lead and registrar, are they tracking okay, do they need to be escalated, do we need to do any further work with these guys? Another really important thing we do is try to give ownership of the patients to the RMOs and to make them part of the clinical team. So another one of their very early roles every shift is to make formal contact with the leadership on the wards they're allocated. So they will approach the shift coordinator, do a formal board round where they know who every patient is briefly on the hospital, not in detail, just every patient in their area. Are they tracking okay? Are the nurses worried about them? Has there been physiological change? Are there any major urgent jobs to be done? And we also ask that every patient who's transferred into a safe area during a shift has a protocolized safety check. It's not repeating the work of the admitting team, but it's just confirming that the patient, when they arrive on the ward, is clinically stable, they've been seen by someone, there's a plan's been made, if appropriate, the plan's been actioned. And all the housekeeping that sometimes gets missed has been done. They've got proper analgesia, the VTE prophylaxis has been written up or documented as contraindicated, and the patient's stable, no one's concerned, they're ready to spend the night on the ward. Now, the other little feature, I wasn't going to wade in on this, the great debate of yesterday, ICU versus home teams for METs. There is actually a third way. So SAFE now, well, from next week, will actually provide MET coverage for the whole hospital 24 hours a day. It has been for the last 18 months out of hours. What that means is there's a very small group of registrars and nurses who lead the whole Met service. And those registrars and nurses are all drawn from that little group of people who love Met. They actively have an interest in it. They want to move it forwards. They're proactively trying to improve the quality of the Met service. It minimizes your training requirement, and for that group of people, you can actually focus on much more interesting training than just BLS, ALS, running the defibrillator. You can start talking about non-technical skills and really actually moving them to a much higher level of functioning. They can then disseminate that information to the relatively transient junior members and actually deliver teaching at the bedside on METs. Minimal operational impact from doing that. Your admitting medical registrars are still free to admit. Your ICU registrars are still free to do their ICU ward round. But we support these guys with protocolized and mandatory escalation. So every Met call must be discussed with the relevant consultant at the first opportunity. And there are formal protocols for which patients need to be discussed with ICU. So these guys are supported through that process. Does it work? Look, any intervention like this is pretty difficult to quantify. In terms of mortality, 2015, before we implemented it, our hospital SMR was 91. The first year after we implemented it, it was 66. Lots of changes in WA Health, lots of interventions in the hospital at the same time. We can't say this is down to our service, but hopefully we're at least helping and it's a signal that things are going the right way. The other thing that we've looked at is whether our in-to-out-of-hours mortality ratio has improved. So you remember at the beginning you were significantly more likely to die if you were admitted at the weekend. Now the odds are equal. These are relatively small numbers, actually. This may still be within the realms of chance, but again, it's a signal that we're on the right track, I think. Also helping us think that we're on the right track is the qualitative feedback we've had from the staff. So the nursing staff consistently feel better supported. They feel the patients are being reviewed faster and more appropriately. And the RMOs feel that they've self-quantified that the care that they're providing is at a higher level. The other little bit of signal that I've got is that the conversation of severe adverse events out of hours has changed. So the things that I was investigating before I took over this service have all stopped. You know, people bleeding and not being controlled, all of that stopped. The worst SAC one I've had to look into in the last 6 months out of hours was someone who failed to put a cannula in, so a dose of antibiotics was missed, which to me is a really positive thing. Now, one of the things I've kept hearing over the last couple of days is that a proper Met service is expensive. I put it to you that that's wrong, that a proper service is actually quite cheap. There was an expense setting this up, but what we've mostly done is repurposed people who were already working at night and brought them into a team and made them work more effectively. There are some extra staff, but what we showed was that the fact that you have a reliable, trustworthy team that comes in at 4 o'clock and takes over your jobs and will do them meant that there was an immediate and sustained reduction in overtime. So you can see here, this is where we introduced the service, January, and you can see immediately there's a drop in all junior medical overtime. So our registrars dropped from 19 FTE equivalent to 14. The RMOs from 9 to 4 FTE of overtime, and interns from 7 FTE to 1 FTE of overtime. Now on the WA Industrial Award, that works out at $160,000 a month, about $2 million a year saved in overtime just at the time of implementation. Look, I could talk about this for a long time in detail, but I'm more than happy to answer any questions. This has been a big team effort. There's been a lot of people involved, and I particularly acknowledge the implementation team, particularly Catherine Burkett and Deepan Christensen, who are at the back. And really, this was executive-led and couldn't have happened without the belief of our executive team. If anyone's got any questions, please do email me. I'm more than happy to talk about this.